All right, good afternoon, everyone, and thank you for joining us for our final AAA cost collection webinar of 2020. Thank you guys for joining us. I know a lot of you guys have been with us here before, but if you're new, I just want to let everyone know that if you'd like to ask a question at any point during today's webinar, you can do so by using that Q&A button on your menu. We will either get to those questions throughout today's presentation or at the Q&A portion at the end. Today's webinar is going to be presented by Scott Moore, Brian Werfel, and Asbel Montes. And the last thing I want to do before we get started is just really thank Savick Buying Group, who's been an outstanding partner to the AAA this year. They've been the exclusive sponsor of every single cost collection webinar that we've done over the past 2 years. And they also partnered with the AAA to give free cost collection education grants to over 200 ambulance services throughout the country. I'll be sure to send some additional information about that grant, which we will be extending to all AAA members in 2021. So I'll include some information about that in my follow-up email this afternoon, but I want to go ahead and introduce Mickey Schulte, the Executive Director of Savick, to say a couple words and get us started. Thanks so much, Mickey.
Thank you, Megan. Appreciate it. Again, Savick is thrilled to sponsor the webinar series and support the AAA in this important endeavor. So I'll keep it short and sweet today. Thank you all for the support and the purchases using Savick contracts. It's been a trying year, but we're doing our best to help support you. And we've been able to support you in some other ways this year. And recently, in the past few days, we've been able to get our hands on nitrile gloves, N95s, wipes, and some other material that may be in high demand. So if you haven't gone to savick.com and gone to our online store, I would encourage you to do so. We're doing our best to help fill the holes that you need right now and try to keep you all safe and secure when you're doing the work that you're doing today. So we really appreciate everything that you do out there for everybody here in America. So thanks once again. We're thrilled to support, and I'm going to hand it over now to Scott Moore.
Thank you, Mickey. And I want to echo Meg's thanks to you and all the folks at the Savick Buying Group. You guys have been an amazing, really, partner in this entire cost collection effort over the last, well, greater than now at this point a year. So thank you very much for everything that you guys do. And if you haven't already done so, please go over to the Savick Buying Group website. As we said, membership is free. And of course, you become eligible for those cost collection grants. So I'm Scott Moore. I am the AAA's HR and operations consultant, joined today by my good friend Asbel Montes from Acadian, the Acadian companies, and of course, AAA's Medicare consultant, Brian Werfel. So just what a crazy year it has been. And so we've been through now, this is our 12th program in a row for cost collection. And this program, as with all of the others, if you are an individual who has a certification through the National Academies of Ambulance Coding, I have my Chief Ambulance Compliance Officer. This program is good for 1 hour of continuing education credit. As you all know, Doug Wolfberg and Steve Worth and the folks over at PWW have been partnering with us and helping us as part of our faculty for the cost collection efforts over this past year, and will continue to do so in the coming year. As we always do before we start any of these programs, just a quick disclaimer: the American Ambulance Association and its consultants and speakers do not provide legal, accounting, or financial advice. If, of course, you need legal, accounting, or financial advice, you need to contact a licensed and certified professional within your state. The purpose of this program today is really to be educational. So just as a quick reminder, as all of you have probably heard by now, hence the reason we're even, this was originally scheduled to be, you've been selected for round or for year 2 of cost collection. And we found out just recently that they have announced a delay for cost collection again due to the pandemic. Well, just as a reminder, as we do every time, and people are probably, feeling like, okay, you've said it ad nauseum. One of the reasons why cost collection exists in the first place is, of course, the Bipartisan Budget Act that was passed back in 2018. And this was the act that was going to continue those add-on payments that the AAA and others have been advocating for again and again and again for years, that 2% urban, 3% rural, and 22.6% super rural. Those add-on payments to try and make, so essentially bring our payment and fee structure up such that we aren't losing money when we do those transports, although arguably most of us think that that amount isn't really even adequate as it is. But one of the things that Congress said, and they said, listen, while we appreciate the fact that you guys have advocated over and over again for these add-on payments, this is really the last time we're going to do it. So we'll continue those add-on payments through 2022. However, we need reliable data, cost-related data. Almost every other provider type in healthcare has to provide some form of formal cost reporting to Medicare. We are one of the only provider types that has not had to. So initially, Medicare wanted ambulance services to provide full-on cost reporting, very, very, very involved process. And we advocated that we thought that that would be far too burdensome for the ambulance and EMS organizations around this country. We know that roughly 85% of the EMS agencies in this country bill Medicare less than 2,500 trips a year and 75% less than 1,000. So we know that for the majority of EMS agencies, there are small rural and super rural organizations. And we thought that the cost reporting, formal cost reporting, would be too burdensome for them. So what we pushed for was this cost collection, which is sort of like a light version of cost reporting. You guys have all heard this now, certainly at least 12 times in the 12 last webinars, but really more than that from us between the regional workshops and all the other efforts that we've made. The idea behind, or why this is so incredibly important, is really this is an opportunity, the first time since the late 90s, to try and reform the way that EMS agencies are reimbursed by the federal healthcare program. So by Medicare specifically, right? Changing it from that existing fee structure and even possibly from the distribution amongst the different fee structures. So opens the door for innovation, allows potentially for new treatment options such as treatment in place or telehealth or some other opportunities. Really, it's an important step in the evolution of EMS. And it's critical, as we've talked about, that one of the challenges, and Asbel's going to, and Brian will talk about this in a minute, one of the challenges that we've had is we've gone back to the legislators to say, listen, EMS agencies are struggling in this country. We have seen an enormous amount of publicity over the fact that EMS systems are on the brink, right? That they're really struggling to survive. And in fact, we've seen many small rural EMS systems that have downright just closed. So what they've said to us time and time again is we need data, because what we know from previous GAO reports, right, that often what they said was the data was unreliable, that in fact, in many of those instances, any data that was collected, of course, was voluntary. Who reports voluntary data? People who have the ability to report voluntary data. So, and is that necessarily reflective of the entire EMS industry or profession? And we think not. So what we do know is initially there was going to be this 4-year cost collection period. It was going to start in the first reporting year would be 2020, or data collection period. And we know that back in 2019, they picked the first 25% of EMS organizations that bill Medicare. And then they were going to, and should be any day now, picking the second 25% of EMS agencies to report. And what was going to initially occur was one group, or one 25% group, reporting each year. So initially, right, they passed the proposed rule back in July of 19, and they passed that final rule in November of 19. Actually, we were all at our annual conference out in Nashville. Then they also, in December, published that first 25%. And what was going to happen was that first 25% were going to begin collecting data in 2020 for reporting in 2021. And then the second 25% would be picked in 2020 of December and start collecting data in 21 for reporting in 22. What happened, though, of course, as we know, was that we hit a couple of roadblocks, right? We have the pandemic hit in January, February of last year. So at some point in July, CMS announces, look, we're going to delay cost collection for 1 year. So what we knew was they were going to take the services picked in year 1 and the services picked in year 2, and have them both report on year 2. What we heard just recently, though, is that, and this was just reported last week, that they're going to delay cost collection another year. So what that will mean is, and the reason, just if it's not clear, is because the pandemic, right? They're feeling that possibly the cost that they might, or the data that they might collect from organizations around the country, may not be reflective of what it typically or generally costs to provide EMS services to the people in this country. Well, we don't really disagree with that, but what we do know is we can't continue to kick the can down the road, because if you look at the rest of this timeline, this would mean that essentially the group that's going to be picked any day now, so that at least 50% who are going to be reporting data on next year are actually now going to get bumped to the following year, which means that functionally 3/4 of the industry, or the 3/4 of the ambulance services, will all be trying to collect their data in 2022 for reporting, which is required 5 months following the end of their year, whether it be fiscal or calendar, for reporting sometime in May of 2023. Well, the problem with that is that the report to MedPAC, from MedPAC back to Congress, is due in March of 23, which means that technically, if folks wait until the end of that 5-month period, for those who actually are calendar-based reporting, that actually MedPAC won't have any of our data. So that's going to present a pretty substantial or significant problem. And we've been tossing around amongst the faculty what this could mean. And so this is where I want to bring in, Asbel and Brian, of course, and start talking about what are the implications of the delay. At least, we certainly know that, right, at least we may have, if every organization that is supposed to be reporting or collecting data in 22 and reporting in 23 were to report that data. One, we're a calendar reporter, which would mean that their year ended in December 31st of 22. If that's the case, and they reported almost immediately after, right? So that Medicare had that, or the CMS had that data early enough to be able to then take 3/4 of the industry's data and crunch those numbers, formulate some conclusions from that, put it together, draft a report, which we know will probably take the better part of 2 to 3 months anyways, and then try and report that to Congress. So Asbel, just can you maybe walk through what are some of the maybe top 2 or 3 issues that you think, or impacts that this is going to have now that we're seeing this second delay?
So the first delay was already problematic, just in the timing and the pass through of data. The second year, it's pretty much not a good thing for the industry. This is not something to celebrate on, because now we've got to go back and figure out what are the next steps. The most obvious next steps are, because there is a 2-year delay, is that we seek Congress to do a 2-year on the extension and a 2-year delay on the MedPAC report. So I will guarantee you the advocacy work that's going to happen here is kind of 2-pronged. One is delay make the extenders eligible for a 2-year extension through 2024, and make the MedPAC report another 2-year extension. Because if we do not do that, this is where the problem starts. Number one is there's a lot of data out there. So we're going to kind of talk through this over the next several slides as well, is that there has to be a voluntary data reporting system. No longer can we wait on saying, oh, we're going to have a first pass through of data. We can have a voluntary, we can be inputting data into Amber, as well as whatever the first pass of providers that were a part of the first selection criteria. And typically with data, whenever it's being done the first time, we always know there's going to be nuanced changes. You never base anything on a first pass of data. It's usually going to take a second or third pass, because now we have another delay. And so you technically, as you just said, Scott, we're going to have 3 selection, basically 60% of the industry reporting in 1 year at one time. And there's a very narrow window to even even if they could do it, even if CMS could do it and run through the data and get that information and get it, and have MedPAC's able to sweep that data and come up with a report, even if they were to do that, the probability of that happening is less than 1%. I mean, I just don't see that happening at all whatsoever. The likelihood that that happens is not going to happen. So there has to be a voluntary, because if we do not do that, number one is we put ourselves at risk of the 2012 MedPAC report that basically looked at it, get rid of the extenders, rebase the monies, give it to the emergencies, take it away from the non-emergencies, and do whatever that they were doing through that process as well. So if we remember some of those nuances, it was very interesting what the MedPAC came up with. It was adamantly not correct what they were doing. And so that is the one piece that we face. The second is with HHS reporting and people reporting based upon the COVID, and Brian Werfel will go through that as well. It's a very selection, but in the absence of data, where does the government usually go? Into repositories where they can pull data from. And then it's up to the industry to look at that. So there's very limited data, as this report is showing, on what we actually have as a industry. And if we will go back to when we got our 5-year extension, there were some ambulance agencies that had to get together, aggregate, and pull data to just show you're not paying us adequately. And so now that we've had a 5-year and a data, the most obvious advocacy point is to just say extend by 2 years. And that is probably something that we need to get on board as well. The second thing is, sorry, go ahead.
Well, I was just going to say, but just so we're clear, right? In order for, as of right now, that's a legislatively required report. So that's going to require some wrangling on the part of folks like you and others to go advocate to get that report date moved.
That is correct. You would be absolutely correct. So whatever that we would do for an extension, you would also do for an extension of the MedPAC report. So anything that we do, guys, remember the extender expires the end of 2022. The MedPAC report isn't due until 2023. So anything that you would do would be in tandem with the two. That's all I'm going to say. It doesn't mean that MedPAC has to wait until that mandate report. They could actually come up with a report if they wanted to do it, I guess, and kind of issue their own study on this. It's not really predicated on that. However, you would want to extend it because there's not a set of data available unless we do something with this HHS data that you're going to start reporting on, which I think, in my opinion, is probably the biggest risk that we have if we don't get the reporting piece right for HHS and make sure it's very clear and concise, because there's a lot of nuances around that reporting right now. There's a lot of confusion. As you know, when you look at 150 pages of FAQs, that's all you need to know of how confusing even HHS is around the reporting requirements. So I think that that is something to note as well. And then also we've always got, guys, that CMS could take it upon themselves, or the legislative body could take it upon themselves to do another survey and survey members like the GAO did to try to come out of something to make a recommendation back to Congress. So right now, because it has stalled, this is not a good thing. I know many people that were selected are probably like, I've got another year. For many of us on this faculty side of it, and that we're also looking at it from an advocacy point, how we actually justify all this other innovation that's happening, it is not a good thing. And so now we're trying to figure out plan B, and really the voluntary reporting piece of it. And I know many of you that are on this call are already, we've had 200 grants given to ambulance services. It's going to be really at critical point now to get people to voluntarily start working the reporting process. So we have a data set, if we're not careful, could impact the rural and super rural communities, because if they look at data from companies that are very large that can actually produce data, typically that is not really a picture, as you said earlier, Scott, that really paints what the industry is as a whole. And really understand the nuances of that industry. So I know I hate to say doomsday, because I normally am a very positive, optimistic type person. But to me, this delay is not a good thing for the industry. It's not a good thing from all the work that we've been doing. And I hate to say it that way, but if that makes people say, hey, I'm going to voluntarily do this, we are going to have some type of industry-wide effort. And that is not just the American Ambulance Association. We've taken the lead. We've done a lot of great stuff. We've got some software stuff that we've tried to make this very easy for people to do. But we've got to get people on board with looking at it and submitting their data in a very consistent manner that we can use for the future, or we're going to be where the home health industry was, as we have talked about over and over again, and we're going to see gregarious cuts to all of this. I mean, that's just all there is to it.
Yeah, and I think one of the things we had talked about back, if I go back one slide, where we say they may use other data, right? And I say assumption because the difference between an assumption and a presumption, folks often say, oh, I know, and ask out of, no, it's drawing a conclusion with no fact. And so what I think we want to be very, very careful about is, one, to your point, I'm nervous that the industry goes back to disengaging. We tend to be a very reactive group of people who, until we have to do something, we often don't. And I think it's important that actually we need to lean into this, right? Because we do have this opportunity, right? More time to make sure that we educate folks on exactly what's required. I do think if we were to present to Medicare in a year or two some data, right, from our industry that was, systematically collected, that was arguably, because it was systematically collected, what was universal definitions, using already the framework that Medicare, who has vetted, right, they've vetted their own tool. If we can take that information using things like Amber and actually turn around and produce that information for them, it gives them an opportunity to possibly tap into that data. I understand that there's a congressional mandate. I understand that they have to do some, but at least it allows them to have some information upon which to either pivot, which we're going to talk about in a second, and or at least go, all right, we can, maybe if we're going to do a GAO study, we can use some of that information, right? Because if GAO did a study or a survey, it would, the parameters or the area for which they could get that data, if I'm not mistaken, they arguably could come to a set of data like ours if in fact it were used as a reference point, whether in fact they actually do or not. But I think,
well, and Scott, I think ultimately MedPAC makes their recommendation to Congress. Congress is really going to control what happens with our reimbursement structure, and we're going to need data. So the MedPAC report advising Congress either puts us on the defensive if it isn't to our liking, or it's not representative of the industry. But ultimately, that's the data set that we need to talk about moving forward, because most people thought when we got it, great, this is a 5-year extension, this gives us time, but we're 2 years. We are literally 2 years out, and the 117th Congress is going to be the determining Congress that determines the extension of our extenders, or making them permanent, or doing something like that with it. So literally, this is the next Congress that we are all going to be working on this again, and we have no data. I think we need to understand that very clear. We have no data, and this doesn't have a happy conclusion unless we voluntarily do something.
right. And so that comes back to the whole idea behind, Amber and or systematically collecting data, right? So we know we've got the tool that Medicare has produced, right? Arguably, they would have they would at least provide some deference in the fact that the tool that they created in the first place, that tool was vetted. If we can take and have our folks and look at delay as an opportunity to, basically do nothing for the next 2 years. If we can take that delay and actually start to lean into that, start to collect that data systematically in something like Amber, reporting that data, then we can start to prepare for what, right? We're going to get an idea of what it's going to look like when 3 years gets reported based on one, or 3/4 of the industry get reported based on one. We can start to formulate a plan both offensively and defensively. So Brian, I don't know if you have anything to add on that. You look like you're prepping to say something, but I know, we were talking about this need to be agile and getting into about accurate and reliable data being more important than ever. And the need for us, and we talked about this on the faculty call, is okay, well, we need to still push the cost collection in the systematic collection of data in Amber, but then also getting back to, and this is the part where I'm going to hand it off to Brian, is this utilizing, being very clear, because we know that Medicare, or we know that HHS is going to have a bunch of data in the next year about our industry, some level data about COVID and the impacts of COVID and the use of those provider relief funds. And we all, I think, share some level of concern that there may be, that data may get used to draw some conclusions or assumptions. So what I had asked and wanted to ask Brian if he would do was start to go through those provider relief requirements and talk about, I think it's more important than ever that we get this right, that folks understand what's supposed to be done. And then, and because this is the next speed bump, I guess, in the travel lane for EMS agencies, right? Starting, they said possibly, initially they said they were going to open this up in October. Now they're saying, Brian, I think January 20 something, if I'm not mistaken.
January 20 something. I just don't off the top of my head remember
I think it was 20
where we land there. So
yeah, do you mind taking folks through some of the PRF requirements?
sure. So before I do that though, I think I just want to both follow up and then sort of take a different tact on Asbel's point about where this data is going to be used. So there is its design purpose, which is to help HHS get comfortable with the notion that the relief funds that were given to not just our industry, but all industries were appropriate and did not result in any entity, in their language, ending up being more profitable as a result of the relief funds than they would have been had the pandemic not occurred. So, as each of you go through this reporting for the HHS Provider Relief Fund step, that is absolutely the short-term goal, is to certainly report these funds for that limited purpose of justifying the relief that you got. I think Asbel's point, though, is a valid one in the sense that the entire premise of the cost data system and the MedPAC report is that up until this point, neither Congress nor CMS had a representative data set of the industry. The problem was always going to be that even in the best case scenario, they weren't going to have the full 100% of the reports in by the time they ended up issuing the MedPAC report, but at least they would have had 25% of it, and then potentially some additionals, early reporters in that second cohort. But now we're not even going to have that, right? So it is possible that in the absence of the larger cost data, MedPAC may look at these reporting relief fund act. Now that being said, I would argue that in doing so, MedPAC would almost have to qualify that the information that we're asking for is different than overall profitability, and that by its very nature, in fact, the only reason these reports exist is because we are not in a normal period of time, right? MedPAC's goal is to decide what the profitability of the ambulance industry looks like under normal circumstances. We are in anything but normal circumstances right now, and this relief was targeted as a result of that. So to me, it's comparing apples, not just to oranges, but to, giraffes, but it is a data set. So, okay. So big picture, the relief funds you got were intended to serve a very limited purpose. They were designed to help you compensate for either the increased expenses that you incurred as a direct result of the pandemic, or to compensate you for lost revenue that resulted from the nation's larger response to the pandemic, the economic lockdowns, and the change in patient behavior that came with the pandemic, right? So, as Scott notes on the slides, this is not free money, and there are strings that are attached to it. If we can move up one. So initially, the way the reports were going to work is that there was a higher threshold in place, and they were going to require quarterly reports. I think HHS realized fairly quickly in this process that was both too narrow in the sense of it was limited to a set of companies that got a higher dollar amount, but at the same time overly burdensome in requiring them to report quarterly. So they then shifted to this new model, which is where we find ourselves today, where any company that gets more than $10,000 will have a reporting requirement. But they then bifurcated it to say that there's two versions of this reporting requirement. There's reporting light, which is any company that got under 500,000 in provider relief funds. And then there's a more extensive report for any company that got more than 500,000 in relief funds. So in our industry, because we didn't get any targeted distributions and simply got the general allocation, which was set at 2% of your total gross revenues, those that are in this heightened or that level 2 reporting requirement are companies that got more than 500,000 in relief funds and therefore in theory have revenues of in excess of $25 million a year. That's probably, it's safe to say that these companies probably have fairly sophisticated accounting systems in place to begin with. So for our industry, this really is probably a very limited, what were we estimating, Asbel? No more than 10% of the industry as a whole, and probably even significantly less than that, right? So the only real conceptual difference between level 1 and level 2 reporting is level 1 allows you to aggregate certain data, certain expenses, whereas level 2 requires you to break out those expenses into their various categories. But what we are suggesting to the industry is, regardless of whether you fall within level 1 or level 2, that you break it out yourself, similar to what you'd be required to do in cost data, right? And then simply aggregate it as a second step for the reporting purposes. And, we will be revising the Amber product to allow you to do that. And our logic, which I'll turn back to Asbel to speak to a little more, is we believe that the best practice should be to approach this reporting requirement using the same financial metrics that you would use for cost data, not because it will be used for the same purpose, but simply because it could be used. And certainly it could be used to, on an individual micro company level, sort of could be used by them to, I don't want to use the word audit, but to sort of look to see if what you reported for relief purposes, where you do benefit from reporting a higher revenue number, matches with what you're ultimately showing when cost data comes around, right? All right, so if we can advance a slide. So in terms of the reporting requirements, and these are attributable, the demographic information, regardless of whether you fall within that level 1 or that level 2. So you will report on the tax ID level, generally speaking. Unless, however, if your company or your organization is structured in a way where you have one entity and multiple subsidiary entities with their own tax ID numbers, you will there be able to file one single report for all of the tax IDs. We still think, though, that just as a best practice, you should probably first do this analysis on the individual tax ID level. Now, for those of you that have multiple NPIs under a single tax ID, the reporting of NPIs is optional on their reporting. However, we still think it's a good idea, best practice, just for your own sake, if you do have multiple NPIs under each tax ID, to list them out just so that you ensure that you're putting the appropriate revenue and expenses under the appropriate tax ID. They will ask you for your fiscal year end date. For many of you on this call, that will be a calendar year. For those of you that have different fiscal years, you'll need to report that. And then they will ask you to use a federal tax classification. This you will get from, frankly, the tax return that you file. As an example, if you file a Schedule C return, you are a C Corp, right? If you file individually, you're probably a sole proprietorship or an LLC, et cetera. But again, they're on your tax returns, there is a classification. You would just mirror that. In terms of the expenses, they're only looking at 2020 expenses, at least in this initial report, the one due in February. So they do break out healthcare related expenses from general and administrative expenses, and you'll need to do that as well. Okay, we'll move up a slide, I guess.
Yeah, and really this kind of comes back to that point that those general healthcare related expenses, the general administrative and operating, and then of course your lost revenues that are not reimbursed by another source, right? That's one of the things that they want to make sure that if you did in fact get a particular expense reimbursed by another source. So this is where you have to get a little bit more sophisticated when it comes to your accounting practices and making sure that you're able to time monies out. One of the things that I know the three of us have talked about before was depending on which source, what the source of funding was, there were restrictions. Some of those funding sources had very narrow restrictions as to what you could use those funds for. So as you're looking at it, and I think we're, probably the horses are out of the barn for many people on this by now, but tie those expenses back to the most narrowly tailored usage first, and then work your way out to the more general usage funds next. So
Scott, can we back up one? I'm sorry.
Sure thing. Yeah.
So a couple of other points just to keep in mind here. So I don't know that we've mentioned this to date on this call, but the way that they will allocate the provider relief funds you got is first to your expenses that are attributable to the coronavirus, and then to lost revenues. So in thinking this through, that's why Scott is suggesting that you first look at the expense side of the ledger and look as granular as possible. So even if you believe that you're in that level one where you're not going to need to break this out, we still think it makes sense to take the expanded G&A expense list and start allocating there. And the other piece here is when we look at, or when we talk about lost revenue, just in case we forget to mention this later, they are looking at a straight comparison from your 2019 year to your 2020 year. They are not making any allowances for any changes in the business of the entity over the 2 years. So this is a static analysis, if you will. So if you were projecting this time last year that you would be 10% bigger this year, but the coronavirus, the effects of the pandemic have been so you started at a baseline of 100, say, and you thought you'd be at 110, but you're off 10% from that number, and therefore you're at 99, right? 10% of 110 is 11, right? In their mind, you're down 1%, not 10%, because in their mind, you were making a projection for how 2020 would look. They don't know if that's realistic or not. However, they do make an exception where the change is attributable to a corporate level transaction. So if you bought a company in 2019 or 2020, or if you sold a company in 2019 or 2020, or if you divested significant assets in 2019 or 2020, you will need to think through where and when that transaction happened and make the appropriate allowances there. And it's in your interest to do so, especially if you acquired a company, because in theory, you would get credit for that larger base when you measure changes against the 2020 change. Sorry, Scott.
No, you're good.
I guess I'll handle this one. So these are the broken down categories of general and administrative expenses. And just a couple of points to mention here. What they're looking for is the changes from year over year. And to the extent that it's attributable in some way, shape, or form to the coronavirus. So using that mortgage and or rent as an example, in cost reporting, what they were asking for is whether or not, let's say you rent a set amount of space, but then sublet a portion of it. They would want to know what your expenses attributable to your portion of it was, not giving effect to the subletted portion, right? Here, what they're really getting at is whether or not the pandemic forced you to take on additional space. That would be the expense they're looking for. So it's not your overall overhead for this item. It's whether or not you incurred any additional expense. So if, for instance, in order to keep your field personnel segregated, you leased additional space so that you could spread them out further, so that rather than have all 10 of your crews, all 10 of your EMTs and paramedics in one room, you thought it made sense to segregate them into smaller pockets so that one wouldn't infect the others. That expense would go on here, right? The cost of the new space. So in going through all of these and in attempting to allocate expenses, what I would suggest is using what lawyers call a but-for analysis. So for every item you're talking about, the question you're asking is, but for the pandemic, would I have incurred this expense? If that answer is a yes, or a no, rather, sorry, a no, right? In other words, had the pandemic not occurred, I wouldn't have incurred this expense. It's not going to be reportable here, and therefore you're not going to get, quote, credit for it, right, against the provider relief funds. So as you go through, just keep in mind that they are looking for the changes, not the totals. Anything you want to add, Asbel or Scott?
The only thing that I would anticipate, and what we're anticipating that to be, is you'll have to upload your financial statements of year over year, but what you're going to key into the data collection tool that's supposed to be live on January the 15th is these totals, as Brian is indicating, the changes. But you are going to have to upload financials and things like that. So you need to have this stuff prepared in advance, because you're going to get 30 days. Technically right now that could change, because it's, the timing is everything. So I would anticipate that possibly could be pushed back, is what I'm anticipating to happen. But right now there is the January 15th piece that you're going to look at, and you're going to have 30 days to get it in. So don't wait till the last minute. Just start looking now if you are over the 500,000. If you're under the 500,000, it's going to be aggregated. You'll still have to upload stuff, but you're not going to have to provide this detail in the tool.
Yeah, and one other comment that I'd make is that you did say that you'll be uploading those supporting documents, right? Understand that again is going to be data that they are going to have access to, and as we understand it, we've seen documents where public record of PPP loans that were made out to organizations. This information again will be arguably public record, right? And so I think it's important that folks recognize that part of why we're harping on this, and we think folks are pretty clear. One of the things that we've seen in the last 2 years of really talking about cost collection is that depending upon the sophistication of the agency is the sophistication of their ability to report data, or their accounting systems, their financial systems, and recognizing how those things carry across the different departments within your organization. So what we're suggesting, go ahead. Yeah,
the only thing I want to add to that, and the reason why we keep talking about this and correlating it to the cost data collection tool, because in many of the examples that they're giving in this, especially with hospitals and nursing homes who do cost reporting, they are actually referencing their cost reports, the line item number on their cost report that would correlate to this change here. They actually reference that. And that is kind of why I have indicated it is very important that we understand that if the agencies are looking at things like this and they're actually talking about it in the hospital and nursing home context, that what takes away from them saying, you know what, wait a minute, we were using all that information for the HHS reporting for CARES Act. Why can't we just go back there and use the information and do a reverse flip for the EMS industry, because we don't have the cost data collection yet? And they were all inputting all this data in. That is the only reason why I'm saying that there obviously is a marriage between the two that they've already noticed, because they're referencing it when you get to the nursing homes and hospitals. And that's why I've always said, pay attention to what all the other provider groups that they're doing with the other provider groups, because there's a correlation happening here. Doesn't mean that they'll do that in 2 years. It just means that they have figured out how to connect all these dots. And so it's really important that we get this piece right and understand it.
Right. And understand that the people at HHS that look at this, will be looking at this information, probably come out of their cost data groups, so they're used to certain terms having certain meanings, and that's in part why they're referencing back to the existing cost reporting industries. Now we don't have cost reporting. We would have had cost data, but of course that's been pushed back. But again, just to make your life easier, the way we were going to use those terms for cost data, we should be using them here as well, right? And in terms of, these financial statements, we don't think at this point in time that they are going to basically audit your financial reports. We think they're just going to look at those larger financial reports to see if the information you're putting here makes sense. In other words, if you're reporting that your expenses for supplies are 3 times higher than they were, but the financials for the 2 years show that you actually spent less on supplies, that might be a red flag to them, right? So,
and so one question that came up, and I'll pass it off to either one of you, regarding uploading financials. What is your recommendation regarding what we should upload? Upload audited financials, audited financial package, BSIS cash flow, financial statement notes, or just an internal generated financial statement? So, for example, a QuickBooks, generated financial statement as opposed to something audited. Audited financials, I know, are incredibly expensive. Not all.
Right. I think it's more internal because of the way that they're structuring all the FAQs.
Yep.
I mean, you're really going to have to piece stuff out that maybe would not be on your audited financials. It's going to be internal generated. That is really their intent.
yeah, I think I would answer the question the same way, but with a different logic, which was, I think that they've recognized that not everyone would have audited financials, and the minimum bar they're setting is something you've produced, right? In answer to the person that asked the question, there in theory shouldn't be much daylight between your audited financials and your own internal financials. And for the immediate purpose of justifying the relief that you got, I think either one would work.
And when you submitted your tranche 2 or tranche 3 application, you had to upload in many instances worksheets or other documents.
What I was going to say is the likelihood that you, for the tranche 2 and 3, you probably use your internals for 2020 because your auditeds weren't prepared yet.
Just be consistent in what I've told everyone is be consistent in everything that you're doing.
Right. So
what will trigger you is to be inconsistent.
And Asbel's going to say, keep it simple, stupid. Right. So I think those are probably our 2 best guiding principles here. Right. Yes. So the revenue one is it's actually simple to report because it's a static analysis. If you know what your revenues were in 2019 and you know what your revenues are in 2020, this will be very easy to report. Right. And again, since you probably won't have audited financials, if you're on a calendar year by February of 2021, you're probably using the P&Ls you have internally.
Right.
They are, I'm sorry, going to ask you to break out this by calendar quarter, though, in addition to the year. So what they really want to focus on is the first and second quarters of the 2 years, similar to what you did in tranche 2 and tranche 3.
Yeah, and then they are going to ask you to do some of these personnel metrics. Now, one of the things that we noticed in the reporting requirements that were put out by CMS were really, it was for brick and mortar style organization, right? They were looking for a number of beds, that kind of stuff. We're actually taking those. So what we've done is taken the post payment reporting requirement documents from HHS, and we've sent them off to the folks who helped develop or who developed Amber, with an intent of asking them to help us develop because we probably can't pivot right away, Amber, to meet that post-payment reporting requirements. And we're looking or will integrate some of that. What we've asked them to do is to create, the folks who developed this were really functionally accounting folks in addition to being software folks. And so they're taking and creating a worksheet that we can use and distribute to members so that we can really try and, again, make sure that folks are doing things consistently. As we talked about early on in cost collection, one of the challenges that home health experienced was they didn't agree on terms and definitions. One of the things that we have harped upon time and time and time again, every time we presented, is everybody get on the same page about what we mean. Because if in fact the data is disparate, outliers get tossed. So what we want to make sure is that we all agree. And often what we hear from legislators and or regulators is you guys are not on the same page. And frankly, that hurts us. And so what we're looking to do, it's in everyone's best interest to come to terms and an agreement about what these definitions mean. So we did have, and I'll show you just briefly a snapshot of that worksheet at the end. We are working with the folks who developed Amber to be able to provide a tool for folks to help to kind of put this together. The other reason is want to be able to take some of that data and have them, again, there's a firewall between us and them, so that the data, we can start to do some analyses of our own, or they can start to do some analysis of their own on the software side. So there will be some metrics that will be adjusted to reflect what EMS organizations have, as opposed to what your typical brick and mortar healthcare institutions have. One of the things that we just want to really focus on are, these are expenses, right? Tie expenses to one-set of funds. Do not double dip. That is one thing that they say time and time again, not reimbursed by another source. So this is where we've been saying, this is again something I feel like you probably want to hit me with. But at this point, go back to your underlying systems, those scheduling, payroll, accounting systems, and make sure that one, you're using consistent terms and either export codes across those systems to make sure that you're recognizing if in fact you've added a bunch of staff to do COVID testing, or you've added a bunch of staff for special COVID transport units. You want to know in your systems who those folks are. Don't just list them as an EMT. We often used to run into this. If you had an EMT working on a wheelchair van, right? That's not an EMT for the purposes of reporting ambulance personnel. That's a wheelchair van attendant. That would be something that you want to make sure that you have the ability within your systems to identify those additional staffs, those additional payrolls that might be segregated from your typical business, right? So that you can identify that. So go to your systems now. Don't try and do it after the fact. That to go backwards and try and fix something is often very challenging. So set that in place. Now we know many of you already have, right? These are expenses from 20, but don't add insult to injury. If you haven't done it already, sort of get on the same page, make sure you've noted somewhere when you made the change and why you made the change, so that it's obvious to whoever might have to come back and take a look at that. All right, and just make sure that you're consistent across all systems. Right? Where you can, put in identifiers for COVID.
Scott, you also want to talk about, to the extent they've made a change in their payroll, how much they pay people. So,
right.
Tracking that, that's likely going to be the largest single expense that you have.
Yep.
So if you're paying hazard pay, essentially, right?
Hazard pay, and then that pay, of course, if you paid hazard pay, we all know that that's going to affect, depending upon how you did it, that might affect your overtime pay. So what might be keyed is overtime pay, because you had to do a weighted average overtime for certain hazard shifts. Again, you just need to be able to track that stuff down, right? This is where, you're sort of sometimes, and I mean, accounting folks are not always known as being terribly exciting. This is where you want to engage. They're going to feel like, put me in, coach, I'm ready, right? This is where you're going to want to get with those folks and say, you really need to be talking with them. This comes back to closing periods consistently. I know Asbel, as a rev cycle person, I argue this over and over again. Do not close your period whenever all the trips get in, right? Because if you're closing one period on the 27th of the month, but closing another period on the 5th of the month, if you're a cash accounting person, you are going to have very different looking periods, and you are going to have a whole bunch of challenges in trying to show period over period changes, and could be quarter over quarter. We know they're looking for Q1 and 2 of 19 versus Q1 and 2 of 20. Well, if Q1 and 2 of 20, you happen to close so much further down the path that you could really cause problems with your numbers. So be clear about that. Just a quick question. So if we had extra overtime due to many of the staffing being out with COVID, is that something that we would need to use? Great question. That is in fact attributable to the pandemic. So if you had a whole bunch of folks being out on quarantine and or out with the illness,
right? So, but for the pandemic, those individuals that were out would not have been out. Therefore, you would not have needed to pay other individuals overtime, right?
Yep. Great question. And another really good question. We've been adding an additional half hour on the end of every single shift for the purposes of disinfecting, or on the end of every transport, actually, for the purposes of disinfecting. Is that something that, yes, but for the pandemic, you would not have done this? So these are fantastic questions that I think sometimes might get missed. So by asking it, by the way, if others on the webinar have questions, it's important you ask it, because you may put something in someone's forefront and memory that they hadn't previously thought. Also, if we paid employees for their time out in quarantine, 2 weeks, should that be included? Of course.
But for the pandemic, I went to quarantine them in the first place.
One thing I do want to caution you about, there's a Family First Coronavirus Act Response Act. If in fact you are going to take the tax credit on the back end of that of the payroll tax, well, you just need to make sure, right, that you're not double dipping. So that's really, really, really important. If you happen to.
Well, I think what they should do, I think the easiest way, Scott, to explain that is take all the expenses,
yep,
and then go and take all the additional revenue you got in credits, add that to it, whatever's left over in an aggregate form is what you can use. But that's the easiest
For
way
these
to do
purposes, you would have additional revenue that is equal to the value of the tax credit you get.
that. Yes.
Yes.
But that's a minor portion,
Correct.
6%
Yes.
of
Minor.
the amounts you spent.
Yes.
And so just quickly, because I know we're coming up on the end of the hour, by the way, thank you to all the attendees for the questions, because those are fantastic. And just so you know, if we don't get to them, you can ask them after, and we'll make sure that we get them out. But just remember that any of these documents need to be retained for at least 3 years. I know a lot of folks hold that out far, far longer, but just be sure that anything related to the pandemic specifically, and the use of those CARES funds or other financial relief related to the pandemic, that you're maintaining for a minimum of 3 years. So this just quickly was our first shot at, Aaron Director, who many of you have seen before, demonstrating Amber. And of course, there is the transactional side of Amber, which is blue, which they're furiously working on. That is the part that we're really hoping we would have game day ready earlier in the year, but we'll keep you posted. But this would be that spreadsheet for really in our effort to put out to members. It's, we're still going to tie it up within the next week or so. We'll get it out to members. The purpose of the spreadsheet, though, will be to get members to report all in a consistent manner. And we're going to make this consistent with the tab that'll be in Amber, and the ability to then pull this data in an aggregated form into the underlying platform for us to do some analysis, so that when we're talking with Medicare, if their results are grossly different than our results, we can say, we can, as I said, both offensive and defensive opportunities. So the importance of collecting that data. Now, I believe I have in here, and I don't want to brush past it too much. I know we've got some questions. One more. Is there an equivalent FFCRA tax credit for government or tax exempt agencies? I'm going to get back to you, Linda, on that question, because I want to confirm many of the early provisions within the law. Actually, there were pivots or changes. So I just want to go back and confirm, but I'll get back to you, Linda, on that. Great question. So if you have questions, of course, you can always email, as always, any of the faculty members at info or acefaculty@ambulance.org. Of course, you can also submit any questions to the AAA in general at info@ambulance.org, and we will certainly respond. Don't forget the subscriptions and the cost collection grants. Those are still out there, right? Our collaboration with the SAVIC Foundation, making this available, because we knew that, in fact, we are going to live and die by the data. So if you haven't already done so, SAVIC membership is free. Come over, report, or apply for that cost collection grant. So this is just a quick look at a few of the screenshots from Blue. This will be that transactional area. It really is, we're sort of keying it as a QuickBooks for EMS agencies or public safety agencies. And this will also tie into, of course, the cost collection. My sinking suspicion is that cost collection is not going away, right? There still will be this requirement to report your data. And I think we'll probably be reporting data long after that MedPAC report is submitted to Congress. So We are preparing for the long haul. Again, every single time folks like Asbel and Kathy Lester and the rest of the group are in legislative offices talking about our industry and advocating on behalf of the industry, almost every single question is, it's great, we agree, we think you guys are wonderful, where's the data? And so this is where we have, as an industry, not helped ourselves. And so what we're suggesting to you all is, this is the time, right? Trust, but also verify. We need to actually formulate our own data, and we probably should have done it even years ago. So just, I get to join these two gentlemen again in just under a week for just we decided we thought we needed to do a webinar that talked about, we've covered a ton. I think in one day last year, I did 3 webinars in just one day. We've covered a ton, and so much so that I've even forgotten some of it. So our hope with this webinar next week, and we touched a bit on some of this today, is to cover really, this is really related to the pandemic. We're going to go back and reschool ourselves on everything that has come out, but just a reminder, right? For example, someone asked a question this week about the $5,250 that an employer can pay off of an employee's school loan, that that would be a tax-free event for them and a deductible expense for the employer. Of course, that expires at the end of this month. So, but those are the kind of things that there are still opportunities out there, and things that, frankly, there was a lot done, and lawmakers really did move and hustle this past year. And that means that guys like Asbel and Brian and the rest of the group and Kathy all hustled as well. So join us next Wednesday on, if I'm not mistaken, 18th at 2 p.m. Eastern for this wrapping up a year for the record books. Forgive my using the toilet, but this has been day 7,565 of 2020. And I just want to thank not only all of you for attending, but of course, Brian and Asbel for always being the safety net under my little high wire act. So I want to thank you all. I'm going to pass it back off to Megan to close us out, who will probably have a few closing announcements.
Awesome. Thank you so much, Scott, Brian, and Asbel. A great job as always. And like I said at the top of the call, I'll send out an email at some point this evening with a recording of today's presentation, the PowerPoint slides. This is also a NAC certified webinar, so I'll include that certification as well. I'll also include a link and some information about the AAA membership and the SAVIC grant. And if you have any questions about that, of course, feel free to respond, and I can either answer your questions or connect you with the best person. Again, thank you so much. I know a lot of you guys joined us for most of our webinars throughout the year, so we really appreciate it. We're happy to have you on, and if you have any questions, please don't hesitate to reach out. Thanks again, and have a good, happy holiday, everybody.